Welcome everyone. We'll be starting in just a moment. Welcome to today's webinar. We'll be starting in just a moment. We'll be starting our webinar in just a moment. Okay, well, it looks like a fair amount of people are populated in our webinar, so I'm going to go ahead and get us started. My name is Heather Zemo. I'm the Education Director at IAHSS. Welcome to today's webinar, IAHSS Industry Benchmarking Data and Analysis, Special Focus on Incident Reporting. If there is time at the end of the presentation, which I'm sure there will be, we're going to have a Q&A available. The Q&A is at the bottom of your screen, so I ask that you please put your questions in that section and use the chat feature to introduce yourself. Please don't put your questions in the chat feature. They tend to get lost. So the webinar, just so you know, is being recorded, so you will have access to that after. The PDF of the slides will also be available. Well, it may be next week sometime though, so I might not have it to you this week, but it will be available to anyone who had registered. I think that's all my housekeeping notes, so I'm going to go ahead and introduce our speaker for today, Scott MacMillan. Scott, I'll turn it over to you.
Excellent. Thank you very much, Heather, and welcome everybody to today's webinar, where we are going to delve into in more detail than we've had the opportunity to do so far on the IAHSS Benchmark Dashboard, in particular the Incident Benchmark Dashboard. And if the number of folks that are here today is any indication of the interest that's out there for this, then I think we are off to a fantastic start. So thank you, everybody. Welcome. I also want to give a special welcome to those of you that are here today that are representing some of our vendors. In particular, those that are representing security incident reporting systems, because today is all about looking at the dashboard. And there's a lot of opportunity for you as system providers to be able to further enhance your products, to be able to help our members who are looking to contribute their data to the dashboard. So let's get started. Okay, so at the end of today and the next hour, my goal is for all of you to become familiar with the purpose and the benefits of the Incident Benchmark Dashboard. So we'll look at what it can do for you. We're also going to look at the what. What is it that we're collecting? What categories are we collecting? What department information and what facility data? And the facility data is especially important because that's the filters that we can use within the benchmark dashboard. Then we're going to look at the how. And the how pertains to how the data needs to be formatted in order for it to be uploaded into the benchmark dashboard. Unfortunately, it needs to be in a standard format in order for us to be able to do the level of analysis that we need to do. And then we're also going to look at preparing to submit data to the benchmark dashboard. And as many of you know, we are going to be launching this next year. So we'll look at how it is that you need to set up your data beforehand. And we're going to separate it by year one versus all other years. Okay, because the reality is in the first year, there might be a little bit more work required, particularly related to the mapping, that once you do it in year one, you don't have to do it again after that, because we don't change our categories and we don't really change departments very often. So a little bit of extra work in year one, year two after that, it's going to be significantly easier. Okay, so we're going to separate and look at those differently. We're also going to look at, as I mentioned, those of you representing the incident reporting systems, we're going to kind of do a summary of some of the opportunities I think that are out there and some takeaways for you on how you can just even further enhance your product to be able to make it even easier for our members who want to contribute their data. So we'll focus on that specifically. So what is a benchmark dashboard? This is kind of a scaled down definition for one that we've given at the AC&Es in the past, but basically the dashboard is a central repository of healthcare facility security and safety incident data, which we then use to create benchmarks. And then you, members, can use those benchmarks to compare your data so that you can make evidence-based decisions, right? Now, I'm one of many people that are involved in this project. This is something that has never been done before. This has never been done in healthcare security. And so as you can appreciate, there's a lot of people that are working on this behind the scenes. We've got members of the IAHSS, and we've got 3 different vendors and organizations that we're using as well. So I'm not going to go through all the names because you guys have access to these slides afterwards. But I do want to focus on Osmos, the one in the middle there in the black. They're the ones building a mapping tool for us. Okay, so we're not just asking you for your data. We're doing everything we can to help you to be able to give us the data and to help you get the data in the format it needs to. And so they're building a mapping tool that we're going to kind of look at what that looks like. And then Nucleus Analytics. Nucleus are the ones actually building the dashboard for the IHSS. They're the ones hosting the data, building all of those visualizations and the benchmarks for us. So interest, the fact that there's so many of you on this today is amazing. And if that's even a small indication, then as I said, we're doing fantastic. So we kind of envision that there's 2 different groups within the IHSS that's going to use the dashboard. One is, and we hope it's all of our members that work for security and safety programs who are going to provide their data. You would be kind of the data contributors. They're going to put your data into the dashboard, right? And there's some perks that will come to that. If you're willing to contribute your data, you'll get access to the dashboard. Then there's the members that will just use the data. But there's also a host of different agencies and organizations that are external to the IHSS that have a significant interest in using the data. Vendors, for example, can use it for marketing and research and development to enhance their products. Professional associations, I've given several presentations already. I'm thoroughly excited to be going to Indianapolis in the next couple of weeks to give a presentation to the Indianapolis Hospital Association and the Indianapolis Coalition for Patient Safety. Government agencies would love to get their hands on this data for research, as would academics, and even the media comes to the IHSS with requests for data that we haven't been able to provide in the past. So a significant amount of interest in this, which makes it a success already. So what does it look like? This is actually a preview for you folks. So you're seeing for the first time the crime survey dashboard that we are launching very, very soon. So we have partnered with the foundation. Many of you know the foundation for the last several years has been running a crime survey. Many of you on this webinar may have contributed your data to the crime survey. Typically, it's been published in a PDF document. We have partnered with them to now take that data, build a dashboard, which allows you to take advantage of some of the interactive features and functions of the dashboard. So for example, on the right-hand side, you'll notice that there's some filters. Okay, there's 2 filters in particular. By clicking on, for example, the licensed beds, you get a different range, which allows you to now filter the data so that it's, for a size of a facility similar to yours. So it allows you to narrow down that data so it's more relevant to you. Now, that's just 2 filters for the crime survey. In the incident benchmarking dashboard, there will be significantly more filters available to you, and you'll see just how many when we look at the facility attributes data. Okay, so this just gives you kind of a look and feel of what the dashboard entails. This is just another way that the data can be visualized. This happens to look at each of the different crimes that were submitted and how they trend over time. We've got roughly 6 years worth of data for the crime survey, which is fantastic. And then again, this is just another way that the data can be visualized. This just happens to show the each category and the percentage based off of the total respondents. And the incident benchmark dashboard will be similar visualizations, but obviously different data that will be contained within that, and a lot more data and a lot more opportunities to be able to do those comparisons. Let's talk a little bit now about benchmark. What is a benchmark? Well, essentially it's something, a kind of normalized number that serves as some sort of standard that allows us to make comparisons to that, okay? And within the benchmark dashboard, one of the standards that we're going to be creating is based off of rates. When comparing data from one site to another site, it's difficult to do that using just the actual numbers, just like it's difficult to compare the crimes in one city to the crime in another city. It needs to be normalized in some way, and that's usually done based off of population. Hence, crime rate is based off of the population. So we're going to do that in the benchmark dashboard with different types of normalized numbers. And we'll look at some of those examples, okay? So the rate formula is quite simple. It's A divided by B and then multiplied by C. You will calculate this rate for your site using your data, And then you will use that rate to compare to the rate within the benchmark dashboard for sites that are similar to yours. So if we look at an example of that rate, how it gets calculated, let's say that A equals total violence at our site, and we had 476 last year. Then we want to compare it to inpatient days, because inpatient days is a measure of patient volumes, how many patients we're serving in our facility. And let's say there was 12,500 last year, hypothetically. Okay. And we're going to create a rate per 1,000. Now you can do it per 10, per 100. It doesn't really matter. It just changes the decimal essentially. But because there's 12,000 inpatient days, 1,000 is makes sense to use as the rate. So if we did the simple calculation using that formula, 476, we divide it by the 12,500, we multiply by 1,000, that gives us a rate of 38.1 violent acts in our facility for every 1,000 patients that are staying in our facility. That rate can now be used to compare to the rate within the benchmark dashboard, okay, which is a far more accurate comparison than just trying to compare total violence to those other sites, right? So with that in mind, let's take a look at some of the benefits that the dashboard can offer us, okay? And in particular, we're going to look at certifications. So the benchmark dashboard will allow you to make determinations around whether or not you should, for example, invest in certain areas within your program based on the potential benefits it might have to you. So in this example, we can look at certifications because that's some of the information that we collect from you on an annual basis. How many of your staff have the basic, advanced, supervisor, and CHPA certifications? So let's say our facility, this is a hypothetical facility, we do not offer that certification to our staff. Okay, and we have calculated a rate using that simple formula that we looked at of 18.5 total incidences across our facility per 1,000 inpatient days. We can now compare that to sites that are similar to ours that offer, for example, basic certifications to their staff. Sites that do, it turns out they've got a 15.3 rate. That's a 17% reduction in total incidents for those sites. Facilities that offer advanced certifications to their staff, 30% reduction compared to our rate. Supervisor level, 51%, okay? And CHPA, 70%. Now, these are fictitious. These are arbitrary numbers that don't actually exist yet because we haven't built the dashboard, but it gives you a sense of how you could use the rates to determine whether or not it might be worth for you to invest. In this case, it's certifications for your staff, okay? And it gives you the evidence to get the funding to do that. Let's take another look. This time, let's look at security resources, okay? So we're gonna look at whether or not we, and again, our hypothetical facility, should invest in putting dedicated security resources in 3 key sensitive units within our facility. But before we look at the rate, we're gonna first filter the data, okay? Because we kind of talked about some filtering options. So in this case, in our hypothetical example, we're going to compare a site that's like ours. And our site is an acute care facility that serves all ages, essentially a hospital that serves the entire population, okay? Not to be confused with other facility typologies that we'll look at. It's also publicly funded. We want to compare to a site that's publicly funded as opposed to one that's, say, for example, for profit. Our facility happens to be in an urban area, and it has between 700 and 800 beds. Okay, now that's just 4 filter options of many that are going to be available to you in the benchmark dashboard, but it gives you an idea of just how much we can narrow down so that we're doing the most accurate comparisons possible. Okay, and we're going to look at a rate of total incidences per bed, and we're going to do it per bed because we're looking at specific units. So we can actually calculate based off the number of beds in those units that rate and make comparisons that way. So we're going to look at whether or not we should invest in resources, a dedicated security officer in our emergency department, dedicated security officer in our behavioral mental health unit, as well as our pediatric unit. Now, in this example, right now, I don't have any. I don't have those resources, okay? Here's the rate of incidences per bed specific to each of those units. I'm now going to take that and I can compare it to sites that meet those same filtering options to determine whether or not it's worthwhile for me to invest or consider investing in those resources. As it turns out, a site, facilities like mine that offer and have dedicated resources in the emergency department, they have a rate that's 30% lower than I'm seeing. behavioral mental health unit, they're seeing a 36% reduction in those units in total incidences per bed. And then pediatric, 52%. Okay. Now, again, these are arbitrary, these are fictitious numbers, but it gives you an idea of how you can use this benchmark dashboard. First of all, it allows you to determine whether or not, should I do this? Should I invest? Does it appear to be worth it for me to invest in these additional resources relative to what is happening in other facilities? And the answer in this case would be yes, it absolutely is. But further to that, this is the quantifiable evidence that you can use to go to your C-suite to convince them to give you that funding. Because unfortunately, gone are the days where our gut alone is sufficient to be able to convince the powers that be to give us the funding. Right? So this is just an example of how we can use it, looking at certifications and resources. Now I just want to talk briefly about the data and how the data kind of comes in and where it goes. I think it's important for you to understand that when you're providing your data, what happens to it when you provide it. So on the left is the data source. That's your data, however you collect it. If you use an incident reporting system, you would pull the data from that reporting system. If you collect it in a spreadsheet, doesn't matter. However you collect it, your data is what's going to go into the system, okay? In a specific format, which we'll look at a little bit later on. That data goes into that IAHSS mapping tool that we talked about before, all right? And that's where you would map your categories and your departments. It also has validation, which is fantastic. So it can tell you if maybe this data is in the wrong column or whatever the case might be. It doesn't meet the criteria, so you can fix it, because we want to make sure, of course, that the data is top quality and ensure the integrity of the data. IAHSS will also de-identify the data. So for example, it might go in with your healthcare facility name or the acronym that you use, but it will be replaced by a unique number before it gets sent to the actual dashboard, all right? So then IAHSS sends the data to Nucleus. As I mentioned, Nucleus is building and hosting the dashboard, and that's where Nucleus will take the data and they will build all of those benchmarks. They'll build those data visualizations, the graphs, the charts, the trending, okay? They'll build those filtering options as well, right? And then the data itself is then presented to you in the dashboard, which is accessible through the IAHSS website. Right? So it just kind of shows you how the data flows and where it goes when you upload it. Okay, I want to briefly talk about the two focuses for the rest of the webinar, really, when we look at it. So back in 2018, as part of this project, and those of you who don't know, this project actually started back in 2016. It's gone through different phases. But in 2018, the IAHSS hired a consultant to work with members of the IAHSS, I was one of them, to provide our data, to analyze it, to see how we can do this. And the question that was essentially answered was, can this be done? And the report determined that yes, absolutely, you can build a data warehouse and a benchmarking dashboard from that data. However, there are two key recommendations on how the dashboard should be built. One is standardized categories. The only way that we can compare data is if we're all using and calling it the same thing, okay? So we are going to look at what those categories are and what it involves to potentially map to those. The other recommendation was that the data needed to be collected in a raw data format, okay, which is the how. And we'll show you what that looks like and how the data needs to be formatted in order for it to be used to be able to do the analysis that we're looking at, okay? So with that in mind, let's look at the what, the categories. So fortunately, at the same time that we were going through the different phases to look at developing the benchmark dashboard or the data warehouse, the council and guidelines for the IAHSS was also simultaneously looking at developing standardized categories that all members should seek to try and collect, which worked out great. As it turns out, the benchmark dashboard is now based off of those categories. All right, and they're in the process of updating them right now. So those will be released shortly, I would imagine. And there's also a glossary of terms that accompanies that as well. So you can see how they're defining certain categories. But it's important to understand that the framework outlines 4 levels of classification. Okay, at the top, the highest level is the group. Under the group, you'll have categories. Under the categories, you'll have subcategories. And in some cases, there'll actually be a 4th level below that, which is the incident type. right? And that's to say the benchmark dashboard treats each of those independent. They're mutually exclusive of each other. And it allows us to create those benchmarks at each one of those levels. So even if you can't go to the lowest level when you're mapping, that's okay, because whatever level you stop at, we can create a benchmark for that level and the levels above it. Okay, so again, it's very versatile, especially when we're using the raw data that we're looking at. So in terms of the group, all of the categories fall into basically 5 groups. No surprise, one of them is violence and aggression. Okay, then we've got other criminal activity, and then there's emergency, and we'll look at that's really internal and external emergencies or disasters. Security assist, which are a lot of the other functions that security provides within our facilities, as well as safety and facility management. A lot of that has to do with some systems related stuff as well. Okay, so we're going to go into each one of those a little bit more. I'd love to go through all of them. You'll see just how detailed and expansive the Guidelines Council were when they created these categories. It's quite exceptional, actually. We won't be able to go through all of them, but we'll kind of take a glance at each group separately. So for the violence and aggression, you can see there's 4 different levels. That's those 4 levels. On the left, it's the group, category, subcategory, incident type. And just to give you an idea of some of the categories, we've got things like abduction, assault, homicide, we've got robbery, sexual assault. Okay, some of them will then have categories below that as well, which is the subcategory. For example, abduction, we can break it down to infant versus kidnapping versus pediatric. And then in some cases, some of them even go to the 4th level, which is the incident type, where in this case, you'll see that they're all breaking it down between actual and attempted for those that have that level. All right. And I can't emphasize enough, it's okay if you can't go to that 4th level. If you don't break it down to that, you map it to the lowest level that most closely aligns to your categories. Okay, we can create benchmarks for each of the levels above that. It's still very relevant. Even if you only map it to the group level, that's still a useful benchmark. When we look at other criminal activity, we're looking at things like arson, burglary, property damage. Theft is one of the bigger ones there you see towards the bottom. Again, most of them have subcategories. And some of them, in this case, I think only theft actually goes to that 4th level, which again, simply looks at whether it was an actual theft or an attempted theft. When we look at emergency, we've got internal versus external. Most of them, they all seem to have subcategories there. For the internal, we're looking at things like hazardous materials versus human related versus technological failure. And then almost all of them have that 4th level where it looks very specifically at the cause of that particular emergency or disaster. For security assist, we've got things like escorts, protection plans, missing persons. Most of them have subcategories. Escort, we're looking at whether it was done on campus or off campus. And then escort's the only one of these ones that goes to that 4th level, which looks at who it is that you're escorting. And again, it's okay if you don't go to that level. You can stop at any level above. We've also got things like patient interventions, security screening, other security support that security provides. They all have subcategories for the most part. And then a couple of them also go down to the incident type level. For security assist, that 4th level, the incident type typically looks at who it is that service is being provided to. And again, you don't have to go to that level if you can't. In terms of safety and facility management type categories, alarm is a big one, and then it breaks down to the different type of alarm, and then it looks at whether or not it was an actual alarm, a malfunction, a test, or a user error for all of them. We've also got things like equipment failure, lost and found, if that's a function that your program provides. Again, different subcategories for equipment. We're looking at the specific type of equipment, and then again, in some cases, it goes down to that 4th level as well. Okay. You also got things like motor vehicle assist, policy violations, slip and falls, suspicious persons. Most of them have a subcategory. And in this case, none of these ones happen to go to that 4th level. Okay. So that was a quick overview of the category framework. Again, that will be released very shortly. The Guidelines Council is just doing an update. We've partnered with them to review the previous framework to make sure that it can best align to the requirements for the data warehouse for the benchmark dashboard. So that will be released very soon, as will the glossary of terms, which is a very important document because that kind of defines for you what it is that we're collecting here with respect to these categories. So if you have to map your categories, you have an idea on what the IAHSS says, how they're defining it, just to help you with that process. So again, look at the categorical hierarchy. We talked about there being 4 groups, and we talked about the fact that we treat them as mutually exclusive. So that allows us to create rates at each one of those levels, which can be used and is important in their own right. So for example, at the highest level, we can create a rate of total violence per 1,000 inpatient days, which we already used in our previous example when we were looking at some of the benefits that the dashboard can provide. We can look at, for example, total emergencies or disasters per bed. We can go one step lower. Within the violence, we can look specifically at assaults and how many of those are happening per 1,000 inpatient days. We can look at how many escorts are happening per square footage. We can go down even further within the assaults. We want to look specifically at total aggravated assaults, and we can look at those per 1,000 ED visits. For every 1,000 people coming to emerge, how many aggravated assaults are happening in the emergency department? We can look at total criminal trespass per acreage, because that's one of the facility data sources that we're collecting. And then in some cases, for those that have the incident type, we can go even lower. Wouldn't it be great to be able to determine whether or not it's worth it for us to invest in weapons detection by looking at the rate of weapons found on patients per weapons detection FTE based off the security hours? I mean, that's quite just amazing thing to be able to do. So it just shows you how the data, even if you can't go to the lower level, again, you go to the map it to the lowest level you possibly can, because there's useful benchmarks that can be created for that level and every level above. So not only are we interested in what it is that is happening, the categories, what type of categories are happening, but ideally want to know where they're happening within the facilities, because again, it allows us to narrow down some of that data. So there's 16 department types, 16 buckets that you will classify or map your areas within your facility to one of these 16 buckets. I won't go through all of them, but no surprise, we've got our typical sort of emergency department. We've got behavioral mental health unit over here, maternal, infant, youth care, anything to do with moms, babies, moms to be, or children kind of would fall under here. There's 3 different others categories, which will probably use fairly prevalently. This other bucket might very well be used most. That, for example, is your administration, food and nutrition, loading dock, IMIT, facilities maintenance areas. Anything that doesn't fall within one of the other units would fall into the other. I do want to point out that there is a suggested mapping priority. You might have a department, for example, that could fit into 2 of these buckets. An example might be, say you had an adolescent psychiatry unit or adolescent behavioral health unit. Technically, adolescent is children that could fall within the maternal. It's also behavioral, so it could fall in behavioral mental health. Unfortunately, the reality is that often there's a heightened risk for violence in behavioral mental health units, unfortunately, and that's a sensitive area of our focus. So it's suggested that you would put it into the behavioral mental health over the maternal in that case. Likewise, it's suggested that maternal, infant, youth care might trump other ones below that, other than behavior. An example of that would be your NICUs. NICU, neonatal, is maternal, infant, youth. ICU actually falls into the critical care. Okay, in that particular case, it is suggested that you would map it to the maternal, infant, youth care. More concerned about the babies in that case than the critical care. All right, so these are the departments. When you're mapping these, you will get to be very good at knowing where these go. Okay, and the mapping tool that we're building allows you to do multiple selections to map it to one of these buckets. So you can very quickly map a bunch of them into one bucket, okay, very, very quickly. So it may seem daunting because you have a lot of areas in your facility, but it actually doesn't take a lot of time. You'll get very good at knowing where these go very quickly. Facility attributes. This is a very important data set. You will provide this every year and you'll update it, but only a few of these need to be updated every year, okay? This is the data that allows you to do the filtering, right? All those filters that we talked about is based off of the facility attributes data, okay? And it can be grouped into to different areas. So each year would be its own version. So you'd update it for each year. And then, of course, you'd have your healthcare facility name. You do it for each of the facilities that you're providing data for. For me, every year, I'll be doing it for roughly 30 facilities. That name gets replaced by unique ID after OSMOS is done with it. We're looking at very limited location information. So where those healthcare facilities reside in terms of the country, the state and province. And then population density. And population density just pertains to whether or not the facility is in an urban, suburban, or rural area. Again, just help filter it a little bit more. Then we're looking at sort of some of the service offerings or the classifications of the facility. Business model is whether or not it's private for profit, private not for profit, or is it publicly funded? Patient service type, is it only serve inpatients, only outpatients, or does it do both? And then healthcare facility type, which is probably the filter that you will use the most, because that is what allows you to filter it to a facility that is similar to yours with respect to the scope of services it provides and the particular population type that you're servicing. So that will likely be one of the most prevalently used filters within the dashboard, which is why we'll take a closer look at it in the next slides. Then we have the patient volumes. All right, as you saw before, this is what you're going to use to build that rate, right? So you got inpatient days, outpatient visits, ED visits, and then if you have specific behavioral mental health or pediatric areas within your emerge, and you collect those visits separately, that would also be provided, okay? Now, the reason that this one is highlighted in red is because this is one that would be updated each year. These will change from year to year, okay? But as you'll see, that might be the only one that needs to be updated each year. You're not going to change countries and provinces. You're not going to change business models from one year to the next. So once that's set, that's done. Then we're going to look at some security staff and training. So the security staffing model, are you proprietary only? Are you contractor only? Are you combination? And then, of course, the other ones look at those certifications, which we've already seen can be used and benefit you in terms of whether or not you should invest in those resources. Healthcare facility size. A lot of these are based off of beds, total beds, beds in the emerge, and some of those specific areas that we're looking at. And then you'll see on the bottom two, we're also looking at total interior space, which is measured in square footage. So sorry for those of you who are Canadians like me, you're going to have to do the math from meters to square feet. And likewise, total property size measured in acres. Right? And lastly, security hours. So each year you provide the total number of scheduled hours, total number of hours dedicated to response, and then other static posts and other specific assignments. And again, that's what allows us to be able to filter the data. For those of you who don't have, for example, dedicated weapons detection, having this information, what it allows you to create that rate and do that comparison, which we already saw when we were looking at whether to invest in dedicated resources in the emergency, behavioral mental health, and pediatric areas. Right? So it seems like a lot. The reason the last three are kind of orange or amber is because they may change from one year to the next. Probably not a lot though, right? Unless your facility adds a new unit, your bed count's not really going to change from one year to the next, okay? Unless you invest in more training for your staff, the certifications might not change. We hope they do. I hope that those increase, obviously. And same with security hours. If you don't get funding to increase your resources, the hours might not change from one year to the next. So while there's a lot of data being collected here in terms of the different data fields, the reality is it's possible that only those 5 that fall in the patient volumes actually need to be updated from one year to the next. And this is what it looks like. The facility attributes right now is something that you'll have to collect and maintain yourself, probably just in a spreadsheet. You can see here that each column represents some of those different data fields. Each row represents one facility. So in this case, this is an example of just 3 facilities. For me, each year I would be doing 30. Some of you might be only doing 1. And again, you only need to update certain one of these from one year to the next. Okay. And then while you might have your healthcare facility name in there or acronym, it will be de-identified before it gets into the dashboard. It is not visible to anybody. Okay. After that. I mentioned healthcare facility types. This is one of the filters, probably one of the more prevalent ones that you're going to use. So you will classify each one of your facilities based off of one of these 10 options. Okay, acute care for all ages is basically a hospital that serves everyone, but maybe you're a children's or women's only. So you want to be able to compare directly to those. That's another option. More so for our US folks there, not as much in Canada, but I understand that freestanding emergency departments is a specific facility type. So that's an option as well. So each one of your hospitals will be classified, or facilities, sorry, will be classified into one of these 10. And again, once you set it, it's likely not going to change in the future. All right, so now I want to spend a little bit of time looking at data mapping. And we talked about the what it is we're collecting based off of the IHSS category framework. In a perfect world, we would all transition to using those categories outright, which would require no mapping. It's a direct comparison because we're using the same thing. The reality is, for many of us, me included, we don't use all those categories exactly. And so we might have to map our category labels to those. Okay, so what does that look like? On the left are actual categories from my program. And we're going to look to see how those would map to some of the categories in the framework. The first one we're going to look at is administrative release of information. Anytime our security staff have to hand over documents or evidence to external agencies, whether it's law enforcement or Crown Counsel or whatever the case might be, we want to document who we gave it to, what we gave them, and when we gave it to them. Is there an equivalent category in the IHSS framework? As it turns out, no, there isn't. And that's completely okay, right? I either don't need to include that data, or when I do, I can simply I have the option to skip those in the mapping tool, and it won't be sent to the dashboard, right? We're going to look at next one we have is called service feedback accolade. Anytime somebody has a compliment or something nice to say about security, they can write a report. Is there an equivalent in the IHSS? There absolutely is. They call it complement of security. It means the same thing. So that's a nice one-to-one map. We still use, in British Columbia, code colors. We haven't transitioned to plain language yet. So we look at a code blue, which is a cardiac arrest or medical distress. That aligns very nicely with internal emergency, medical event, medical emergency. Code green, evacuation. As it turns out, there is not a specific evacuation category in the framework, but I can still map it to the higher level, which is emergency. It is still an emergency, a disaster type situation. I can still add that in there to the benchmark for emergency. Property crime, we break it down to theft, and then theft from patient, theft from staff, theft from visitor. This is a great example where we go lower than the IHSS does. So in this case, all three of these will actually map to simply theft personal belongings. And that's completely okay as well. Heliport operations, security writes a report. They're involved anytime helicopters, medevacs land at our facilities. They write a report. Is there an equivalent on the IHSS? No, there isn't. That's okay. That's fine. We don't need to include that, or we can just ignore it and skip it in the mapping tool. Lastly, we're going to look at, we have robbery, and then we break it down to attempted, robbery versus actual. Similar to theft, as it turns out, we go lower than the IHSS. That's okay. And these would simply map to just robbery. Okay. So just an example of how you can do the mapping for the categories and what that kind of looks like. And again, once you do that, you're done. Year one, you'll do those. After that, you don't need to do them again because you're not going to change your categories that often from one year to the next. If you do add one category, it's going to take you 30 seconds to map that. And then that one is done for the future. Okay. Now we'll look at what it looks like to map your departments and areas. Again, these are a list of actual programs from one of my facilities. Emergency department, no surprise, maps easily to emergency department. Child and adolescent psychiatric unit. That's an example of where it could be maternal infant because it's children, but it's also behavioral mental health. As we suggested, the preferred priority would be given to the mental health. And so that is how that would get mapped. Oncology, this is an inpatient oncology unit. It's going to map to other, but it's going to map more specifically to the other inpatient unit. Behavioral mental health intensive care unit, another example where it could go into critical care because of the ICU element, but it's going to go into the behavioral mental health, as we mentioned, with respect to the preferred priority. Maternity, no surprise, maternal infant youth care. Administration, I know, goes into other. Outpatient lab goes into other, but more specific. This is also outpatient. They come in, they get their dialysis, they go home. So that would also go to other outpatient unit. Palliative care, we've got a bucket dedicated to that. Long-term care, hospice, palliative, so that's easy. Pharmacy is its own bucket. Surgical daycare, anything surgical or general medicine goes into med surge, which is why the next one, medicine unit, will also go into med surge. And then parking lot goes into parking exterior area. Fairly simple. And then coffee shop, as is any other retail shops, would go into interior public space, which would also be any of your main lobbies, anywhere that the public has access to and can go that doesn't fall into a unit would fall into the interior public space. Okay, so again, just a quick example, and it doesn't take a long time to go through these. Okay, it really doesn't. And again, once they're done in year one, you don't have to do them again, unless you build a new building or a new department, in which case it takes you a couple of minutes to map those, and then you're done from every year there forward. Okay? So that's the what. What are we collecting in terms of categories, departments? Now we're going to look at the how. And the how is the raw data. Okay, how does it need to be formatted? If you're not familiar with the term raw data is looks at data at the incident level. Okay, it's kind of the opposite of aggregate data. Aggregate data is total numbers of something. So for example, the crime survey, those of you who filled out the crime survey, it asks, how many assaults did you have last year? Let's say you had 150. Raw data wants information about each one of those 150 assaults, where each one of them happened, what date they happened, and what time they happened. Okay, so that's raw data, which allows us to do a lot more detailed analysis and create more specific benchmarks and rates. And it's actually, in some respects, easier, believe it or not, once you know how to pull it out and get in the format, it's actually easier to do that than to try to do separate reports for separate counts. It also allows us to recode data. For example, by knowing the date of each incident, we can recode that into day of the week. Now we can break it down to Monday, Tuesday, Wednesday. We can convert it into month. So we can create 3 different data fields out of that one data field. If you use other analytical tools like Microsoft Power BI or Tableau, those work very well with raw data. And raw data essentially is in a table format, a tabular format. And we'll take a look at what that looks like. But first off, what is it we're collecting? Talk about the benchmark dashboard. We're saying, you guys are going to contribute your data, and I hope every one of you here that represents the security and safety program is going to do that. What information, when you run your report, what is it that you actually need to pull? We obviously don't want everything. We just want a few select things. We want to know the facility, of course, the report number, the incident category. That's a critical. We need that, absolutely. The date, the time, the department, unit, or area. Okay. Workplace violence typology. So that is actually in the framework. There's 5 typologies. If you collect that for your violence, great. As well as if you happen to collect and identify whether or not external law enforcement was involved in that incident, we would collect that as well. Right. So that's the information that we're collecting. That's what you would pull from your system. What does it look like when you pull that system? Or what does it look like when you upload it? This is what raw data looks like. This is the incident level data. It's a spreadsheet. So when you run your report in your reporting system, or maybe you use a spreadsheet right now to collect it, great. Each column represents one of those data fields that we just looked at. Okay. Each row represents a category. All right. And the important thing here is the levels for categories. So you have different levels. You might have 2 levels or 3 or 4 or 5. Those need to be combined into one cell. All right. To use the data term, and those vendors that are listening, needs to be concatenated into one cell. Okay. And same goes for the locations. And the reason for that is if you have more than one facility that you're providing data for, in locations, for example, you might have a location or a department name called 2 East. 2 East at healthcare facility A might be maternity. 2 East at healthcare facility B might be an ICU. If we were to map them at the individual levels, the system wouldn't know which report goes to 2 East maternity at this facility versus 2 East ICU at this facility. So by combining those levels into one cell, it creates a unique string of characters that is what now gives you the ability to map that specifically, right? Now, if your reporting system allows you to attach multiple categories to a single report, that's okay, all right? But each one of those categories needs to be its own row. So here, for example, you can see the same report number applies to both of these because that report had more than one category attached to it. Okay, that's okay, but they'll need to be their own row because each one of those is counted separately in the benchmark dashboard. So it allows us to do comparisons on each of those categories. So again, vendors that are watching, If your system currently doesn't produce reports that looks like this, please give consideration to to maybe looking at offering that in the future to further assist your customers, our members, in being able to contribute their data. Now, all that said, if your system doesn't do that right now, okay, talk to your vendor, work with them. They might be able to create a custom report for you, okay, until such time that they add that and as a future release to all of the customers, okay, which we hope that they do. All right. But even still, if you can't, okay, you can reformat it in Excel. Okay. Excel is a very powerful tool. And there's ways that can be done. In fact, I recently just learned that Microsoft has now offered their Copilot, which is their AI, their Chat GPT, for those of you familiar with that, in Excel. So it may be very well possible for you to just type in and tell it what you want it to do, and it'll do it for you, which is fantastic. So that's keep an eye out for that. We're also looking to offer videos as well, okay, training videos. So I'll be looking at some of the different formatting ways that some of the systems might currently output, and then I will offer videos for you that will walk you through how you can convert your format into this format, okay? So please, just because yours doesn't come out in this exact format, doesn't mean you can't contribute your data. There's lots of options available to do that, okay? And the IAHSS is here to help you, okay? I just want to briefly now talk about what does it look like to submit your data. So we're going to look at year one first, which is hopefully for you guys next year, because that's when we're going to go live, okay? Because year one's going to take a little bit more time, but it's only that first year. So the first step is looking at the facility attributes data, all right, that we looked at. Those were all those different data fields, because some of them, the beds, for example, the bed count, the inpatient days, the ED visits, that might not be data you have access to within your organization. If you do, great. If you don't, think about who it is that you need to reach out to and establish that contact to find out how you can get that data each year, okay? It could be just a phone call or an email. It probably wouldn't take a lot of time. Somebody in your organization has that data. You just need to reach out to them. So you collect that data. Then step two, you extract your data, ideally in the format. Ideally, it comes out in that format. If not, again, as we talked about, there's lots of options there for you. So don't fret, okay? Get the data into the format, upload into the Osmos mapping tool. You can map your categories and departments right in that tool. It has AI actually built into it as well. It'll give you some suggested mapping options, which is fantastic. And again, you only have to do that once. It will remember you from one year to the next, okay? So you don't need to do it. And you also don't need to do it all at once. You can do a little bit, submit it, come back and finish it off as you see fit, all right? So you don't need to do it all at once. You do one last little verification to make sure that everything maps, you're happy with it. You know, EI is great, it's a great tool, but AI is not perfect. So you might want to just double check to make sure that what it's suggesting is the best way to map it. And then you're essentially finished. You submit the data. At that point, it'll recode your categories and your departments and your healthcare facility name for you, which will de-identify it, and then the data gets sent. That's year one. 5 steps, okay? Most of that doesn't need to be done again next year, the mapping. In terms of time, I sat down 2 weeks ago to do this for me. I mapped 218. That's how many categories that we have in my organization when we look at the lowest level. And it took me about 2.5 hours. I started on a Tuesday at 7:30 in the morning. I was done by my 10 o'clock meeting. Okay. Do the math. It's about 40 seconds per category. Okay. So not a significant amount of time. Now, admittedly, I've been living and breathing these categories for 2 years as part of this project. Okay. But you'll get to be very good at this. And the beauty thing is I'm done. Those are done. I do not have to map any of those again from this point forward, okay? In terms of the department unit areas, I took 3 of my facilities that have a combined total of 1,500 beds. One of them had 900 beds, one of our larger facilities. In our reporting system, that's equal to 964 individual areas, okay? Sounds like a lot, seems like a lot. It only actually took me 3 hours to do that, okay, which is about 11 seconds per area, right? So not a significant amount of time. As I said, you will get very good at knowing which of those 16 buckets to put those into, and the tool allows you to map multiple ones at one time, right? So it's not a lot of time, and you can come and do that. You can piecemeal it as you will. In terms of the attributes, shouldn't take you more than a phone call or an email to try to establish that relationship with whoever might have some of that other data. Once you have the data, actually putting it in there. When I did it for those same 3 facilities, it only took me 15 minutes. That was it, to fill in all those other attributes, right? I know how many hours we've got access to that. 5 minutes per facility. Not a lot. And as I said, you don't have to do it all at once. Okay. So now that's year 1. That's where it's going to be, a little bit of your time at year 1. After that, much simpler, much faster. Year 2 plus, what does it look like? Update facility data. That's it. Take a look at your facilities. You might only need to update the inpatient days and the outpatient visits. Everything else might not change at all. 5 minutes per facility, you're done. Extract your data for the next year, for the previous year. Get it in the format again, reach out to your vendor. Maybe by then you've already got a custom report they've created, and you just now simply have to hit run and you're done. You upload it. It'll remember all of your mapping that you did previously. So that'll all be done. So it should be really just a quick verification that, yep, everything matches and you're done. That is everything that needs to be done for year 2 onwards. Okay. And again, in terms of the time, incident category mapping, not applicable. Done. You did it year 1. You don't need to do it again. Department unit areas, done. You didn't get it. Unless you built a whole new department, it's all done from year 1. You don't need to do it again for year 2. The facility attributes, 5 minutes, ish, give or take, per facility, and you're done. And that's it. And you're ready to go. That's that year's data set. And you can hit submit. And now you can sit back and enjoy and take advantage of the dashboard benchmarks that are there. So that's it. Last slide, I just want to look at, again, for those of you who are on your vendors that are representing the incident reporting systems, in summary, if there's some things that perhaps you could further enhance your product to make things easier for members to be able to provide their data, and in so doing will actually enhance your product, because this is used by others. Any organization or association that wants to be able to compare data is going to have to normalize it in some way, which is going to mean probably mapping it. So the first thing you could consider is offering an internal mapping tool so that members can do the mapping in the very system that's going to provide the data. They don't need to use the Osmos tool. So that's something you can consider for the categories and the departments. Custom data report. We saw the format that it needs to be in. If you currently don't do that as a default, perhaps you could consider offering that as just another report format option, right? Again, where each row represents a category and where the category and location levels are concatenated into a single cell. You may want to consider offering dedicated data fields. We looked at workplace violence typology as one of those dedicated data. Perhaps you have a dedicated drop-down, for those that are IAHSS members. Law enforcement involved, again, could be a yes/no drop-down. Maybe it's just a checkbox data field that can be offered that's available. That would be fantastic. Facility attributes module. Right now, unfortunately, that facility data is probably going to have to be collected by members in a spreadsheet. Perhaps you want to create a module that would allow them to create like profiles for each of their facility where they can upload that information and they can update it year to year. Again, so they only need to come to you and your system to offer all the relative services that's needed. And then lastly, please reach out to me. Those of you that are representing the reporting systems after this, okay, I want to meet with you. I want to chat with you about how we can offer and work together to offer some videos, okay, to your customers, to our members, to help them so that they know how to, maybe they're not familiar with using the analytics tool in your system to actually get the reports. It would be great to have a video, make that available to them. I can do a video for the system I use. I can't do it obviously for systems I don't have access to. So I would love to work with you guys to see what opportunities there are to produce some videos. And that, folks, is it. So right now what I'll do is I'll take a look at the Q&A. If you have any questions that you think of afterwards, here's my email. It'll be in the slides. You're going to get a copy of these slides afterwards. Please reach out to me, okay? And let's take a look at the Q&A here. All right. First question. Facility site, cancer center. Cancer center is not a specific facility type. It would be under what's called a specialty center. So there is a bucket for facilities that serve a very specific patient population. Cancer center would be one of those. So You wouldn't be able to filter specifically for cancer centers, but you would be able to filter for specialty centers. Another example of a specialty center would be if you have a dedicated burn center that only treats burn patients, rehabilitation centers as well. So now that's not to say that we can't create those in the future. We are always going to further expand on the benchmark dashboard. So just because it's not available in year 1 or year 2 doesn't mean that it might not be an option years after that, okay? Because we're continuously evolving and expanding on this. Can you accept automated uploads? Yes, it's built to allow for direct integration to reporting systems, particularly if you use a cloud-based or a SaaS-based, if your vendors, it is built to have that API connection integration, okay? As long as your organization allows that from a privacy perspective, technologically, it's built to allow that and accommodate that. Yeah, great question. Will we know the rate that is being utilized for each reported category while benchmarking? Example, per inpatient bed, census, etc. Yes. So if it's because we're collecting that data separately and we have the categories, we will be able to create separate rates for each one of those. Yes. Do you feel this would work for ambulatory care? We have medical, dental, behavioral, and health services. So I can tell you that actually ambulatory outpatient is one of those particular facility types. So if that helps, you will be able to filter for facilities that are ambulatory / outpatient only as one of the healthcare facility types, so that you can do a little bit more of a direct comparison to that, if that helps. Did you tell us when we expect to get these categories, semi-arid types? I don't know yet. That's the council and guidelines. I know that they've recently approved the recommendations that I have given them with respect to a better aligning to the benchmark dashboard. I'm not sure exactly the timeline, but it would be very, very soon because we are going live with this next year. So I would expect that they will be releasing the new version of the framework and the glossary of terms before the end of this calendar year, I would say. I don't know the exact ETA though, sorry. We're looking at our incident types now. It would be great to be able to. So again, yeah, I apologize. I don't know exactly when, but it's going to be very, very soon because we need those in time to go to launch next year. What steps need to be taken to participate in this system? So right now, you can just start to get ready. The facility attributes, we are going to put together that list of those. So that will be me that will be doing that, or the project team will do that. So we can release those soon because it doesn't have to be released by the council on guidelines. So when you get a hold of those, you can start to, look at, again, reach out to those individuals in your organization that have data that's, that you don't own. Be great. Inpatient days and beds and outpatient visits, I can tell you, is one of the things that we'll be looking to collect. So give some thought right now to where you might be able to get that information from within your organization. But in terms of participation, when it's live, you essentially go through the website, the IAHSS website, and it'll give you the option to contribute, be a participant. And then there will be options to upload the data. Everything will be uploaded through there. That's the portal. All of this runs through the IAHSS website, including access to the Osmos tool. It's just a link that you would get access to. You go to the Osmos, you upload those data sets in there, and then you can start doing your mapping and you're off to the races. Right? And that's it. So perfect timing, 1 minute to go and last question. So folks, thank you very much for participating. I really appreciate it. Please, vendors, reach out to me after this. I want to talk with you guys. I think there's a lot of opportunities to work together. Members that are working for the incident security systems programs, please. We look forward to getting your data next year, okay? And there's going to be a lot more of these workshops as well. If you're coming to the AC&E, I'll be doing an in-person workshop with Jeff Young, where we will delve even further into this. If you come with your categories, we can help you map your categories right there at the AC&E, okay? So more to come on that as well. All right, thank you, everyone. I appreciate it. Take care. Be safe.
Have a good day, everyone.
Thanks.
Bye-bye.